Today I'm going to talk about the state of the art of general anesthesia for cesarean delivery. And again, no disclosures. And I would like to start off by talking about one of my son's basketball players. My son's a basketball player at Eastern Washington University. And I think there's a player named Bogdan Bliznik who just set the NCAA record for consecutive free throws in the season. The streak stopped at 77. It says 74 here, but that's when he broke the record. And I think he's a perfect role model for OB anesthesiologists doing general anesthesia for cesarean delivery because, you know, hitting a free throw in this really chaotic environment, you have to be really calm. You have to have practiced it multiple times and just really focus on what you're doing amidst the chaos, and we have to be perfect. That unfortunately, there's no room for error, and so Bogdan was pretty much perfect until a couple games ago. But and it's pretty hard to be that perfect. But I think we have a little, we're maybe a little easier for us to be close to perfect than what Bogdan accomplished. All right, so this is the recipe for doing a general anesthetic for cesarean delivery. It's what we do at Stanford. It's what pretty much everybody does across the world with a few caveats, and we'll talk about those. But this is something that you have to know like a dance. When I started anesthesia, I had an attending, Frank Sarnquist, who was our cardiac attending, and he said cardiac anesthesia is just a dance. You just have to know the steps and go through it. It's not complicated. And I would say the same thing about general anesthesia for cesarean delivery. You just have to know the steps, but you can't think about them. You've got to just know it. I have residents that say, you know, why don't you have cognitive aids up in the OR and how to do this and stuff like that. I said, when you're in the OR and you're doing a general anesthetic for a C-section, you can't be thinking about like, oh, let me look this up. You've got to actually just be able to know what you're doing. And it's a basic anesthetic. It's not that complicated. And we're going to go through the steps of this and why each step is important. All right, so let's talk first of all about the pre-anesthetic preparation, which is by Citra, and if you have time, you know, give some Reglan. I want to start by saying that if you don't have time for the Bicitra or Reglan, or you forget it, it's not the end of the world, and we'll go over why this is important. So as we've talked about, you know, already in this meeting, pregnant women have a higher gastric volume and a lower gastric pH compared to non-pregnant women. Now these are fasted women, and they looked at gastric volume and gastric pH compared to the non-pregnant woman, and you can see that it's about twice the volume and a few points, you know, about a half a point lower on the pH scale. And if you give sodium citrate, you can see that you effectively raise the pH in both pregnant and non-pregnant women from under 2 to over 6 in this study. But the difference between non-pregnant and pregnant women is that the time that the pH remains above 3 is actually significantly shorter by about a third in the pregnant woman, because again, they're producing more acid, and it's the effects of the Bicitra don't last as long. Now, Reglan is also effective. If you look at this, at these graphs, the black dot is the baseline, the green dot is metoclopramide, and the red dot is placebo, and you can see that your gastric pressure goes down with Reglan, and the maximum lower esophageal sphincter pressure goes up. And so the barrier pressure between the esophagus and the stomach is greater, having given the metoclopramide. And this doesn't take long at all. As you can see, these measurements were done 15 minutes after dosing. So before we talk about this a little further, I just want to say that if you do get aspiration, you have to remember what works is just positive pressure, it's just supportive care, positive pressure ventilation, and rigid bronchoscopy for the particles, and the particles being the most important thing here. If you read Mendelssohn's original descriptions of the condition, it's the women that died of hypoxemia from particles clogging the lungs, not the acid aspiration. And of course, don't do the other things that make theoretical sense, but actually can be harmful. But back to how important is this Bicitra and Reglan? I think it is important that we practice what we've been taught up to now and what's kind of the standard and what we know kind of works, even though we don't have much aspiration. If you look at we've talked a lot about the SCORE project, this serious complication repository that was led up by Bob D'Angelo, and you can see that there were over 250,000 anesthetics, over 5,000 general anesthetics, and there were 0 cases of aspiration. And other large data sets, point to a very, very low incidence of aspiration. And that doesn't mean it doesn't happen, but it means that we've become very good at preventing it to some degree. So in terms of using Bicitra and Reglan for every case, if you have time, great, but it's not that important, probably, but it is good practice to use it if you have time. Now, the other thing I want to mention quickly is that even with general anesthesia, it's important to use left uterine displacement. This is a classic study from long ago in which it showed that umbilical vein and umbilical artery pH are better in the patients that were tilted. And there's been some challenge to the importance of left uterine displacement recently in the literature. And I think that until that proves out, I would still use it. And I think that there's going to be pretty strong backlash against the papers that are coming out saying that it isn't important. Okay, so Bicitra and Reglan, if you can remember it, great. But pre-oxygenation, now this is really, really key. If you remember lung volume changes in pregnancy, the total lung capacity, stays the same. Tidal volume does go up, respiratory rate goes up, and FRC, this is the most important part, goes way down. And the effects of these changes are that ventilation increases so that your PaCO2 goes down, the normal PaCO2 goes down to 30 or 32. So when you're looking at your end tidal CO2, don't keep it at like 35 like you would in the normal OR, 35 to 40. You got to get it down to 28 to 32 when you're managing a pregnant woman. And then, of course, your bicarb goes down to compensate, and your PO2 goes up a little bit also. Now, the consequences of these changes is that the patients desaturate much faster, and pre-oxygenation is more effective and easier to actually accomplish. So how fast do the women desaturate? Well, this is looking at pregnant women and non-pregnant women, and they're induced. First of all, they measure the PaO2 before induction, and then after 1 minute of apnea, they measure the PaO2 again. And you can see that in non-pregnant women, there's hardly a change in the PaO2. However, with pregnant women, there's a rapid decline, indicating that if you don't get that person ventilated soon, that they're going to be hypoxic. Now, the good news, though, is that because they have a low FRC, the nitrogen washes out very quickly, so that it doesn't matter how you pre-oxygenate them. Any method's very effective. 4 deep breaths, 8 deep breaths, 3 full minutes. So don't be that patient, don't be that anesthesiologist who says, hey, we have to do 3 minutes of pre-oxygenation to get the patient fully pre-oxygenated. You just give them 4 deep breaths while they're going to sleep, and that'll be adequate. Okay, now, like I said, aspiration isn't that important of a complication, but if you again look at, go back to the SCORE project, and you can see that failed intubations, are 10 out of 5,000 general anesthetics, or 1 in 500. Again, not that common, but it does happen. It's actually a real complication that you should be prepared for. Now, how do you avoid airway problems? There's basically 4 ways that you do it. You always examine the airway, and we'll go over why. And you do it right before your case. Even though you saw that woman, a few hours ago in the labor room, you still have to re-examine right before you put them to sleep. You need to position the patient properly, especially if they're obese. And you have to have proper equipment available for backup. And then also, you can use preemptive regional anesthesia. For instance, if you have a woman who has an impossible airway, that might be a woman who, even if she wants natural childbirth, you say, well, maybe you ought to have an epidural that we can dose up in an emergency. That's one approach to that. Now, I don't think you should take that so far that you're putting in epidurals early in everybody that you're potentially concerned about having a general anesthetic. But I'm talking about the exceptional patient. That might be an option. Now positioning, like I said, is everything. This is a picture that Sheila Cohen took early in her career and published in the Saul Shnider textbook in one of the earlier editions. And she actually says this is the picture, this is the thing that she did in her career that has probably saved more lives than anything. If you look at this woman, she's a little bit heavy, and you can see that that airway would be really difficult to manage. It'd be very difficult to intubate her with just a direct laryngoscopy. The angle is horrible. The breasts are in the way. Well, the laryngoscope probably wouldn't even fit between her breasts and chin very well. The handle would get in the way, and that would just be a nightmare to try to deal with. Now, by ramping her in the old way, we used lots of towels and blankets, and now we have these nice ramps. You can see that is a really nice angle, and the breasts have fallen out of the way, and that would be a fairly easy intubation as long as you're tall enough to get over all the towels. You might have to stand on a stool if you're under 5'6" there, but that does definitely make the airway a lot easier. Now, other options to the towels and the blankets, like I said, they now have a nice ramp that I'm sure you probably all have. Or else you can just lift the back of the bed up and put the head part down with the Shea headrest on top of that, and that works well also. Now, the other thing that can happen with pregnant women that's kind of unique is that sometimes they've been resuscitated, or they have preeclampsia, or they've been given lots of volume in their labor, and the airway changes in the process of that. And this is a great illustration of that. This is a 32-year-old woman who had a peripartum cesarean hysterectomy for placenta accreta, and she basically had lost her total blood volume and had it replaced. And with that, there was lots of third spacing and swelling. And this is what her airway looked like. This is a picture by Bhavani Shankar at Brigham, and he was taking pictures of people's airway with a special frame that fit over their mouth so he could reproduce that picture later. And so this is what her airway looked like before the surgery, and this is what her airway looked like after the surgery. And that's clearly a class 4 airway at that point. But not only is it a class 4 airway, that's not just a woman with a normal tissue class 4 airway. That's swollen, hard to move tissue. So that's not going to move when you go to do direct laryngoscopy. And I can say the only woman that I've had trouble ever intubating in obstetrics was a woman who had delivered the day before, but then had 10 units of blood given to her in the ICU and then taken to the OR. And you just couldn't, even though she was a tall, thin woman with a long neck and everything, you just couldn't move the tongue to see around the corner. Now, one of the nice things that's happened in the last 10 years or so is that we have video laryngoscopy. And lots of people, now feel really comfortable with that almost as their primary way to intubate. And so the question is, in obstetrics, should we just be doing all video laryngoscopy or doing direct laryngoscopy? And the jury's out on that. I think there's this meta-analysis that has 17 studies with 2,000 patients, and the outcomes are very heterogeneous. And it really depends on the expertise of the operator. So it turns out that, experienced people who have done lots of direct laryngoscopy, they get the tube in significantly faster with direct laryngoscopy. However, residents that are in training, if they use video laryngoscopy, they're more likely to get the tube in on the first shot. I'm not sure what the answer is. I think probably in years to come, we'll probably have screens mounted above the OR table, and we'll be doing all video laryngoscopy, or having something like a scope where you can actually look directly and then look at the screen if you need to. And that'll probably be in every OR. But for right now, I personally like to use direct laryngoscopy just because it is faster and easier. But it's really important, I think, to have a video laryngoscope, very nearby, or it's also completely appropriate just to use it for your first attempt at intubation in a pregnant woman. So I think the real major change in airway management, and it was really decreased the mortality in anesthesia for pregnant women, has been the LMA. There are now 2 large case series that show that you basically can use LMAs for C-sections without serious complications. I'm not advocating that for your routine use, but as a rescue, it's a great idea. Sorry about that. And there are many case reports of using it for rescue. Now, and I wonder sometimes if you look at the case fatality rates for general anesthesia versus regional anesthesia for cesarean delivery, I sometimes wonder if the decrease that we've seen isn't due to the LMA. So if you look at the time, from 1991 to 96, you can see that there still was a significant difference between the case fatality rates for general anesthesia versus regional anesthesia. But in the last time that they looked at it, from 97 to 2002, there isn't a difference. And it was in 91 to 96 that the LMA was introduced, and we became very facile with it. So by 97 to 2002, we were good at using LMAs for a lot of things, including rescue. So I really do think that that the LMA has really helped reduce, has been part of the reason for that significant drop in mortality associated with general anesthesia for C-section. And just to kind of reiterate, there have been large case series, this one with over 1,000 cases. Now, they did all these cases without any problems. Now, granted, they were all fasted and less than a BMI of less than 30, no reflex history. And they used a rapid sequence induction with cricoid, and they kept cricoid on until the baby was out. I don't think that's necessary or helpful. I'm not sure why they did that, but and they actually used 40 milligrams of sucks for every placement of the LMA. And again, probably not necessary, but it does show that you can safely use this in a number of cases, you can safely use LMAs for C-section. Again, I don't advocate that as your routine, but they're great for rescue, I think. Now, the one issue that's controversial is really, should we be using cricoid pressure? And I'd like to, there's lots of studies I could show you and everything like that, but this is one study that it's from Malawi. It is from a third world country. It's a retrospective analysis. And they looked at the incidence of regurgitation with and without cricoid. And they actually had more regurgitation with cricoid pressure. And the reason I think that happened was that I think we often do cricoid pressure wrong, which I don't apply cricoid pressure until after the patient is paralyzed. I don't use it while they're going to sleep. If you do it while they're going to sleep, you're going to make them retch. It's quite stimulating. So I think it creates as many problems as it prevents. So I'm actually at the point where I'm not using it anymore. But again, I never say never. I think if a woman had just had a large meal and came in, I still might be tempted to use it, but I don't place it until the woman fasciculates from the suctional choline. Now for induction agents, we really only have propofol. All the other agents that would be appropriate have their issues for, and so we're really left with propofol. Now, in terms of controlling hemodynamic response to laryngoscopy, I would say that in an emergency C-section, you really don't have time to get out a lot of different drugs and do, give this and that and everything to try to induce the response to laryngoscopy. So for healthy patients, just use propofol. There's not going to be problems from that. They're going to be able to tolerate the increase in the blood pressure that comes with that, but also use a generous dose. Use 2.5, 3 milligrams per kilogram in a healthy, non-bleeding patient. Now, patients with preeclampsia and cardiac disease, as we've talked about ad nauseum in this meeting, you definitely do want to control that response. If you have time, like if it's a severe preeclamptic with thrombocytopenia, you have time, by all means use remifentanil. But in emergency, you don't have time for remifentanil. And maybe you have time to give fentanyl, and there is good evidence that does blunt the response. But on the other hand, you're doing this general anesthetic a lot of times for the baby's condition, and so adding fentanyl into the mix for a baby that's not doing well might not be a good idea. So you can use alternatives, and this nice article that Brendan Carvalho mentioned yesterday from Barb Scavone, esmolol and nitroglycerin are good options, but really, as she states in the paper, there's really not very good evidence for using any of these, which is best or anything like that. But use something that you're comfortable with that you think will blunt that response, because you don't want an exaggerated blood pressure response in these critical patients. Muscle relaxants, fortunately, there's minimal placental transfer because they just don't cross the blood-brain barriers or the placenta very easily, because they are low lipid. They have low lipid solubility and they're highly ionized. And I still use succinylcholine. It's still the fastest for intubating conditions. It's safe for the fetus. There are situations where you want to avoid it, like if the patient has an atypical cholinesterase. But it doesn't cross the placenta, and it provides reliable intubating conditions very quickly. Alternatively, rocuronium is also a viable option, and since we now have Scamodex for reversal, it's appropriate to use rocuronium if you choose to do so. In terms of compared to succinylcholine, in terms of resistance to intubation, like the patient making any responses, it's actually pretty safe, and it gives you a good view, and it only took on average 2.9 seconds longer to actually intubate the patients with rocuronium. In terms of, as soon as the baby's out, you want to decrease your nitrous and add a potent inhalational agent. This is just showing that if you use more than 50% nitrous before the baby's out, the babies are likely to have a lower APGAR score. So until the baby's out, you only want to use 50% nitrous, and then add potent inhalational agents for a little bit more amnesia. Now, awareness is a risk factor in OB anesthesia. This is just a nice little study that showed that if you block the arm of a woman from receiving the succinylcholine, that half of them will respond during the anesthetic. And so that's why I like to give Versed and fentanyl as soon as the baby's out. The good news is that actual recall is very rare. Here's a nice case of a study of over 1,000 patients, and they had 2 cases of awareness, but there was an explanation in both cases. One time they didn't mix up the pentothal correctly, and they basically induced with, distilled water and succinylcholine, which didn't work well. And then they also had a difficult intubation where they didn't redose the pentothal. And so that's also, remember that if you do have a difficult intubation, remember to redose your propofol so that the patient doesn't have recall. Adding a potent inhalational agent doesn't increase blood loss. We worry about that, but it's really at the higher levels that you have a risk of uterine relaxation. But 1 Mac or below, it doesn't seem to increase your blood loss. If you really want to decrease blood loss, you have to use epidural anesthesia. Now, an alternative maintenance would be a propofol infusion, and there's good evidence that propofol doesn't cause as much uterine relaxation as the potent inhalational agents, but I just don't think you have time to use this in an emergency. You can consider it after the baby's out and that there's bleeding, but for true emergency general anesthetics, which is what we perform most of the time when we do general anesthesia for cesarean delivery, I would say, I would just use potent inhalational agents. Now, once the baby's out, you can now switch to 75% nitrous, decrease your inhalational agent a little bit, and then add your Versed and fentanyl, and then extubate awake. In terms of extubating awake, of course, you have to remember that back to that Malawi study I was talking about by Felicity Reynolds, you have to, that patients will regurgitate at times other than induction. And in fact, in that study, the times when they regurgitated was actually 3/4 of the time was other than induction when they regurgitated. So extubation actually may be more dangerous for aspiration and airway problems than intubation. So take care on the extubation, make sure the patient's awake and guarding their airway before you extubate. And so finally, I'd just like to sum up by saying you have to know this recipe by heart. You have to be able to walk through it. We practice it every month with our residents. We actually go in the OR and have what I call low fidelity simulation, where we walk through it. They have to get the drugs out. They have to get the emergency equipment out. They have to know where all this is, and they actually walk through scenarios that we give them so that they know what they're doing. And you don't have time to think at this point, so you have to at least be doing mental reps in your head all the time while you're on labor and delivery and knowing what you're going to do when that stat C-section happens. And you also have to understand this information so that you can adapt it when necessary for when there are changes. For instance, the woman who comes in who is MH susceptible, that's when you need to know that, yes, it's completely appropriate to use rocuronium in this case. And again, I go back to Bogdan, practice your craft, be ready, and do the job every time perfectly. All right, thank you very much.